Good afternoon, everybody. Actually, I'm quite happy to see hall is quite full. So there is a lot of interest in UBE because I know there is a parallel session going on robotics and yes, of course, UBE and Estandu. And you have mixed both. So respected seniors, uh, honorary dignitaries on the dais, chairpersons, and my dear colleagues, I will be speaking on why UBE technique. I'll just give a short introduction about me. I am Dr. Anand Kavi. I am from Pune, and I've been associated with spine endoscopy for more than 10 years now. Friends, traditional spine surgery for lumbar pathologies are mainly the decompressive surgeries like discectomies and stenosis. And conventionally, these are large exposure surgeries with a lot of destruction of the muscles and bones. So this is a challenging approach for a very small pathology in the depth, as we have to go through several tissue layers. And most studies throughout the literature tell us that there is a decreased leg pain with good decompression, but not back pain. And this is due to the collateral damage which we cause due to our approach. Now, final goal of all these surgical interventions is decompression of the nerve, which has to be very safe and definite. So it is the collateral damage which corresponds to the invasiveness of our approach, and that increases the post-operative morbidity. Both of these are my own patients. Now, to overcome these problems, surgical microscope was introduced. Later on, various devices were developed. But I feel endoscopic spine surgery is the most minimally invasive technique as of today. A brief history, full endoscopic surgeries started with the transforaminal approach, with Dr. Hijikata publishing his percutaneous nuclear extraction technique. Later on, Dr. Parvez Kamin published his safe triangle. Then Dr. Anthony Young came with endoscopic inside-out technique. And I would definitely like to mention about Dr. Satish Chandra Gore, my transforaminal endoscopy teacher, who popularized this technique in India and throughout the Asian subcontinent. Some history about UBE. Dr. Anthony published the technical note on translaminar lumbar discectomy using 2 channels in '96. And later on, Dr. Abdul Ghaffar had a poster presentation in AAOS in 2001. And then Dr. Yum Jin Wah and Sang-Kyu Son, both of them popularized this technique. They developed it in Korea and throughout the world. And I was fortunate to get a hang on this technique from both these masters. So people today also ask me that why you are migrating from transforaminal technique to UBE. So basically, transforaminal technique is not the answer to all your problems. You cannot have a single hammer for all the interventions. Transforaminal approach has its own problems, unfamiliar anatomy, very long learning curve. It is quite difficult to adapt to most of the surgeons. And possibility of incomplete decompression is there. Whereas unilateral biportal endoscopy is the same posterior approach. It has a very familiar anatomy. And I feel it is the easiest way to learn endoscopic spine surgery. Because UB combines the accessibility of open surgery. There is no visual or motion limitations. And it combines the minimal invasiveness of endoscopic spine surgery. So basically, UB is 2 ports on the same side of the spine. So it gives absolute freedom to the surgeon. The endoscope and instrument move independently to one another. So it gives the surgeon upper hand with the same surgical indications as in open surgery with no concern of too much tissue damage. So what we are actually doing, the operating area is just the triangular zone between the fascicles of multifidus. So that small triangular area medial to the multifidus is explored. Now friends, endoscope has moved the focus near from the surgeon's eye, that is the microscope, directly to the spine pathology. I will show you this in the slide. Now these surgeries are done under irrigation, so it gives excellent hemostasis, clear vision, there is flushing of small bleeding source due to the continuous irrigation, easy identification of bleeding source, better understanding of microanatomy, and excellent separation of tissue layers. In fact, I have never seen two different layers of ligamentum flavum so clearly until I have started doing UBE. Coming to indications, so all the routine indications of open surgery can be very well tackled by UBE. And with experience, you can also do foraminal and extraforaminal indications. And then you can extend this for cervical as well as thoracic regions. In subsequent talks, we will be tackling some of these. Coming to the instruments, this is again an advantage of UBE. We do not require any specialized instrumentation. Now there was a talk about damage of the scopes. Friends, I'm using a scope which costs 20,000 rupees. It can be ordered on Amazon. It is very cheap. I can use it at least for 50 cases. So I think for 50 cases, if I damage a 20,000 scope, it is not a very costly affair. Whereas I purchase a specialized endoscope for single port surgery, which costs more than 6 lakhs or 7 lakhs, and then I have to buy all the specialized instruments. I think UBE is a completely game changer. A small video clip. So a 65-year-old lady with bilateral claudication symptoms with lumbar canal stenosis, bilateral lateral recess compromise. We do 2 ports. Put the endoscope and your working instrument, explore the small triangular zone called as triangle of Son. We dock the 2 instruments at the spinolaminar junction. We use the RF cautery to clear the soft tissue and identify the bare bone. Once the spinolaminar junction is identified, we start using a high-speed burr. So this is a barrel burr being used.
Dr. Kavi, we are a little bit on time.
Yeah, another minute. Yeah. So we do a limited laminotomy, ipsilateral laminotomy, until you come across the free edge of the ligamentum flavum. And then you can do separation of 2 layers of ligamentum flavum, and the hydrodissection helps you in that. And with this technique, I feel dural tear is next to impossible if you are cautious enough and identify the structures very well. So with that, we can very well do the decompression. We can also go to the contralateral level. So for the want of time, I will skip from the rest of the video. So this is the free lateral recess. You can see the disc there. So friends, whether you like or not, technologies change and new techniques do evolve. So hop on the bus before it's too late. Thank you very much.